All right. So again, good morning, everyone. Oops, welcome. Oops, goodness gracious. Okay, let's start again. Good morning, everyone. Welcome to the Orlando GI Journal Club for March. This is March 6th, 2024, 7 a.m. Eastern Standard Time. Our first study is by De Craker et al. Looking at the treatment of non-constipated IBS with histamine 1 receptor antagonist, Avastin. This is a randomized, double-blind, placebo-controlled trial. IBS is one of the most prevalent GI disorders of the gut-brain axis, affecting approximately 4% of the population. One of the pathophysiological mechanisms leading to abdominal pain in IBS is visceral hypersensitivity. Some studies indicate that mast cell activation as an important mechanism underlying abdominal pain signaling in IBS. And in a preclinical model of IBS, histamine-sensitized receptor potential vanilloid 1 channels via activation of histamine receptors and mediates visceral potentiates and mediates visceral hypersensitivity. The aim of this randomized trial was to evaluate histamine 1 receptor antagonist Avastin as potential treatment for patients with non-constipated IBS. This was a randomized trial. This was multi-center, double-blind. This means that both the investigator and the patient is not aware of the treatment that the patient is receiving. They included all patients with a diagnosis of non-constipated IBS based on Rome 3 criteria, and the patients were assigned in a 1-to-1 ratio for 12 weeks to either 20 milligrams daily of Avastin or placebo. The primary endpoint was the proportion of subjects who are weekly responders for at least 6 of 12 treatment weeks for both global relief of symptoms and abdominal pain intensity. They enrolled 101 patients to the placebo group, 101 patients to the Avastin group. There were generally young patients, mean age of 32 years for both groups, predominantly female, comprising 69 and 67% in the placebo and Avastin groups, respectively. In terms of subtype, the majority had IBS diarrhea predominant, 68% in placebo and 64% in the Avastin group. In terms of frequency for IBS symptoms, they had symptoms for more than 3 days a week in 35 and 29% of the patients in the placebo and Avastin groups, respectively. And actually, daily symptom occurrence occurred in the majority of patients, about 60% in both groups. When looking at the primary outcome, they found that when looking at clinical response, Avastin was superior to placebo with the proportion of patients with symptom relief in 12% in the Avastin group versus 4.3% in the placebo group, with p-value of 0.0471. When looking at the global relief of symptom response, there was no statistical significance between the two groups, with a p-value of 0.0715. However, as you can see, they were able to see a response in 15.1% in Avastin versus 6.9% in the placebo group. When looking at abdominal pain intensity response only, again, there was no statistically significant difference, with response observed in 25% of placebo and 36.6% of the Avastin group. When looking at adverse events, the adverse events encountered were generally minor. The majority of Adverse events encountered was upper respiratory tract infection, 9 in placebo, 6 in Avastin. The next common side effects or adverse events were headaches, followed by potential allergic reaction, which interestingly was also seen in the placebo group, 5 in 5 patients, dry eyes, abdominal pain, and other GI symptoms such as gastroenteritis, constipation, and nausea. The limitation of this randomized trial is that the waxing and waning symptoms of IBS encountered in the study patients resulted in a biphasic placebo response for the authors. And the take-home point from this randomized trial is that Avastin is well tolerated and is superior to placebo in non-constipated IBS and should be considered as a potential new treatment for IBS. The next randomized trial was published in the American Journal of Gastroenterology. It's a randomized control trial looking at propranolol use in patients undergoing ligation for esophageal variceal bleeding. Patients with acute esophageal variceal bleeding should receive therapy for secondary prophylaxis of bleeding before being discharged from the hospital, is the current recommendation, and esophageal variceal banding with use of non-selective beta blockers appears to be more effective than esophageal variceal banding alone, and is recommended as first-line therapy for secondary prophylaxis of esophageal variceal bleeding. But there are potential limitations of non-selective beta blocker use in patients with cirrhosis. Primarily, non-selective beta blockers are reported to be associated with detrimental survival in cirrhotic patients with refractory ascites, impaired circulatory homeostasis and renal function in cirrhosis with refractory ascites is associated with the usage of non-selective beta blockers. And in view of low rebleeding rate after eradication of esophageal varices, the authors felt that discontinuing non-selective beta blockers should be considered if they are no longer needed. So the authors wanted to perform a randomized trial to compare rebleeding rates between patients discontinuing beta blockers and continuing beta blockers after eradication of esophageal varices. This was a non-inferiority multi-center randomized trial enrolling patients with cirrhosis who were admitted with bleeding from esophageal varices. Patients were randomized when hemodynamically stable 3 to 5 days after the first esophageal variceal ligation in a 1-to-1 ratio. Patients either underwent esophageal variceal ligation with propranolol until esophageal variceal eradication, or they had ligation of varices and had propranolol treatment continuously per standard of care, even after eradication of esophageal varices. And the primary outcome was to evaluate the rate of rebleeding in these patients. So the patient characteristics are as follows. 106 patients were enrolled in the discontinuation group, 106 patients in group B, which is continuation of propranolol group. Just a minor point, I don't know why they label the tables group A and group B like this rather than just putting the headings on. It's very difficult to interpret and you have to keep referring to the key. So I'll try and do that when I'm explaining. The key for group A and B is at the bottom, but A is discontinued propranolol and B is continued propranolol. So as you can see, the mean age is 54 years in the discontinued group, 53.5 in the continued group. The etiology of cirrhosis was hepatitis B, hepatitis C, alcohol predominantly. Other etiology only encounted for a small minority of the patients, about 15%. the INR was 1.26 in the discontinued group, 1.28 in the continued group. Ascites was present in 46 and 34 patients respectively in discontinued and continued propranolol groups. MEL scores, mean of 12 thereabouts in both groups. Concurrent variceal gastric varices were also present in 10 and 16 patients in the discontinued and continued groups respectively. So these are the outcome measures. When they are looking at the recurrence of rebleeding, they found in the discontinued group, recurrence of bleeding occurred in 11% versus 10.4% in the continued propranolol group. When looking at the time to recurrence, they found no statistical significant difference in time to recurrence, 67 versus 68 days. When looking at the further decompensation, they found this to be the case in 36% in the discontinued versus 38% in the continued group. When looking at mortality, again, there was no statistical significant difference, 22.6% in discontinued versus 25% in the continued group. Again, there was no difference in the transplant-free survival between the two groups, 57 versus 57.1 versus 57.4 months in both groups. Now, looking at outcomes after esophageal variceal eradication, again, the recurrent esophageal variceal bleeding seen in 4% in discontinued versus 2.8% in the continued groups. And again, when looking at outcomes after variceal eradication, no significant difference in the continued versus discontinued propranolol groups. This is just a repeat of what was presented in the last table. When looking at the number of episodes of recurrent bleeding per patient months, they again found no difference between discontinued and continued propranolol groups with 11 episodes per patient month in both groups. The limitation of this study is that there was no blinding for propranolol administration after variceal eradication, and therefore there is potential for bias in the assessment of the treatment effects. Propranolol rather than carvedilol was used in this study, and results are not applicable to patients with severe jaundice, high-grade hepatic encephalopathy, refractory ascites, and hepatorenal syndrome, as these patients were excluded from the study. The take-home point from this randomized trial is that band ligation plus propranolol only until eradication of varices was achieved was non-inferior to band ligation plus long-term propranolol for recurrent esophageal variceal bleeding, and so discontinuing propranolol after eradication of esophageal varices could be considered in patients who could not tolerate long-term propranolol for secondary prophylaxis of esophageal variceal bleeding. Next is a study by Laut et al. Published in Clinical Gastroenterology and Hepatology, looking at the effect of real-time computer-aided polyp detection system, EndoAid, on adenoma detection in endoscopists in training. The effect of computer-aided polyp detection on adenoma detection rate among endoscopists in training remains unknown. And so the aim of this randomized trial is to evaluate a new CAD-E, computer-aided detection system, EndoAid by Olympus on adenoma detection rate and the colonoscopy quality in junior endoscopists in training. This was a single-blind parallel group randomized trial, adults undergoing screening, surveillance, or diagnostic colonoscopies by endoscopists in training were enrolled. They defined endoscopists in training as those having less than 3 years of experience and having performed less than 500 colonoscopies. Patients were randomized to either undergo colonoscopy with computer-aided detection, CAD-E, or colonoscopy without CAD-E, and the primary outcome measure was the adenoma detection rate. 386 were enrolled into the CAD-E group. 380 groups were enrolled into the control group. When looking at family history of colorectal cancer, 19.5% in CAD-E versus 15.6% in the control group that had a family history of colorectal cancer. The most common indication for performing colonoscopy was having symptoms, about 60% in both groups, followed by surveillance colonoscopy, and then screening comprised only about 7% of the study cohort. When looking at the experience of the endoscopists in training, the majority of the gastroenterologists or in training had performed between 200 and 500 procedures, and there were about 28% of endoscopists who had performed less than 200 procedures. Now, looking at the overall adenoma detection rate, adenoma detection rate was significantly higher in the CAD-E group at 57.5% versus 44.5% in the control group, which resulted in p-value of less than 0.001. When looking at the adenoma detection rate according to the polyp size, the detection rate for small polyps, so less than 5 millimeters, and those sized between 5 and 10 millimeters, there was significant difference between two groups, with CAD-E being superior at 40.4 versus 25% and 36.8 versus 29%. However, for detecting polyps that were greater than 10 millimeters, there was no statistically significant difference between the two groups, and actually the detection rate was numerically higher in the non-CAD-E control group at 4.2% versus only 1.8% in the CAD-E group. When looking at adenoma detection rate by location, again, the CAD-E use resulted in superior adenoma detection rate in both the right colon, here at 42 versus 31%, and the left colon, 34 versus 27.6%. When looking at adenoma detection rate according to morphology, they found that use of CAD-E didn't really result in any significant difference in detection rate for pedunculated polyps, but for non-pedunculated polyps, use of CAD-E resulted in higher adenoma detection rate at 56 versus 39%, with p-value of less than 0.001. For cell-saturated lesion, they found no significant difference between the two groups at 2.1 versus 1.8%, with p-value of 0.801. When they performed a subgroup analysis according to the experience of the endoscopists, so they divided the endoscopists according to whether they had performed less than 200 versus 200 to 500 procedures. And again, they found that adenoma detection rate was significantly higher in the CAD-E group for both beginners at 60 versus 41.9%, and also intermediate proceduralists with a detection rate of 56 versus 45%. Again, when looking at adenoma detection rate according to size, again, for really small polyps, less than 5 millimeters, CAD-E helped to CAD-E group is superior with adenoma detection rate of 50 versus 27% in the beginner group, and 36.6 versus 24% in the intermediate group. However, for polyps larger than 5 millimeter in size, they found that there was no significant difference between the two groups for both beginners and intermediate trainees. When looking at polyps in the right and left colon, again, for right colon, ADR was superior for the CADI group, but for left colon, superior in the beginner group, but not in the intermediate group. The authors also performed a regression analysis to look for variables that are associated with higher adenoma detection rate, and they found that CADI was a significant variable with a relative risk of 1.40 and p-value of less than 0.001. The limitation of this randomized trial is that endoscopists were aware of the randomization group, and therefore there is potential for operational bias. There's a single center only, which may limit generalizability, and the study was not powered to detect a difference between differences in adenoma, advanced adenomas, and sessile serrated lesion detection rates. The take-home point from this randomized trial is that among junior endoscopists in training with less than 3 years of experience and less than 500 procedures under their belt, real-time computer-aided detection system during colonoscopies increased overall adenoma detection rate, especially for small to medium-sized and non-pedunculated adenomas in different locations of the colon and at different levels of experience. However, the benefit of CADI for large and advanced adenomas remains unclear. Our last study is by Labori et al., published in Lancet Gastroenterology and Hepatology. This is a randomized trial looking at neoadjuvant FOLFIRINOX versus upfront surgery for resectable pancreatic head cancer, the NORPACT-1 trial. Several randomized trials have shown that patients who have undergone resection of pancreatic ductal adenocarcinoma should be treated with systemic chemotherapy. Therefore, surgery is integrated into a multimodal treatment sequence that includes surgery and adjuvant chemotherapy. Currently, the standard of care for fit patients with resectable pancreatic adeno-CA is upfront surgery followed by 6 months of adjuvant chemo, preferably with combination of modified fluorouracil, leucovorin, irinotecan, and oxaliplatin, which is known as FOLFIRINOX. The overall survival benefit of neoadjuvant chemo has not yet been proven for patients with resectable pancreatic cancer, but randomized trials published so far did not use FOLFIRINOX. Recently, the SPAC-5 trial found improved survival with neoadjuvant short-course FOLFIRINOX compared with upfront surgery in borderline resectable pancreatic cancer compared with standard surgical resection followed by adjuvant chemo. So these authors wanted to compare the efficacy and safety of neoadjuvant chemo with FOLFIRINOX compared with upfront surgery followed by adjuvant chemo in resectable pancreatic adenocarcinoma. This was a randomized trial conducted in 12 hospitals in Denmark, Finland, Norway, and Sweden. They enrolled patients with resectable pancreatic head cancer and WHO performance status of 0-1, patients randomized in a 1-to-1 ratio to neoadjuvant FOLFIRINOX followed by surgery plus adjuvant chemo or upfront surgery with adjuvant chemo only. There was no masking of patients, and primary outcome was overall survival at 18 months. 77 patients were enrolled in the neoadjuvant FOLFIRINOX group. 63 patients were enrolled in the upfront surgery group. And the median CA19-9 was 149 in the FOLFIRINOX, in the neoadjuvant group, and 182 in the upfront surgery group. In terms of presence of comorbidities, this was present in 49% in the neoadjuvant FOLFIRINOX group and 54% in the upfront group. Now, looking at the primary endpoint of proportion of patients who are still alive at 18 months, so survival at 18 months, they found that patients who underwent upfront surgery were still alive at 18 months versus 60% in the neoadjuvant FOLFIRINOX group, which resulted in a p-value of 0.032. When looking at the secondary endpoints of median overall survival, there was borderline significance with p-value of 0.05, with longer numerical survival in the upfront surgery group of 38 months versus 25 months. When looking at median progression-free survival, there was no significant difference between the two groups at 12 versus 16 months, p-value 0.22. Proportion of patients who were alive and disease-free was 38% in the neoadjuvant FOLFIRINOX versus 44% in the upfront surgery group, with p-value of 0.35. The type of surgery performed was, in the majority of cases, pancreatic duodenectomy, performed in 97% in the neoadjuvant group and 91% in the upfront surgery group. When looking at the resection margins, R0 achieved in 56% of the neoadjuvant FOLFIRINOX group, 39% in the upfront surgery group. And this again, this was statistically significant. R1 resection margin seen in 44% in the neoadjuvant group and 61% in the upfront group. The final diagnosis was ductal adenocarcinoma in 73 of neoadjuvant versus 56 patients in the upfront surgery group. Other types of tumors were distal cholangio, duodenal adenocarcinoma, and pancreatic adenocarcinomas, chronic pancreatitis. There were 2 patients in the upfront surgery group. And the reason is because this study did not mandate biopsy of the lesion prior to undergoing upfront surgery. This is just a survival curve looking at the overall survival in patients undergoing upfront surgery versus FOLFIRINOX. And as you can see, the log rank p-value was 0.05, hazard ratio of 1.52, and looking at progression-free survival, log rank p-value was 0.22, and hazard ratio is 1.3. The limitation of this randomized trial is that histological proof of pancreatic ductal adenocarcinoma was not mandatory before randomization, which influenced the number of patients with non-pancreatic ductal adenocarcinoma diagnosed in the final analysis. Masking, of course, was not possible in the study, and implementation of neoadjuvant FOLFIRINOX, the author's report, was challenging. So the take-home point is that the present trial did not show any overall survival benefit of short-course neoadjuvant FOLFIRINOX compared with upfront surgery in patients with resectable pancreatic head adenocarcinoma. Although survival in neoadjuvant chemotherapy group was in line with other trials, survival in upfront surgery group was markedly better. So to recap, Avastin is well tolerated and superior to placebo in non-constipated IBS and should be considered as a potential new treatment for IBS. Band ligation plus propranolol, only until eradication of esophageal varices, was non-inferior to band ligation plus long-term propranolol for recurrent esophageal variceal bleeding. Therefore, discontinuing propranolol after eradication of esophageal varices could be considered in patients who could not tolerate long-term propranolol for secondary prophylaxis of esophageal variceal bleeding. Among junior endoscopists in training, real-time computer-aided detection system during colonoscopies did increase overall ADR, especially in small to medium-sized and non-pedunculated adenomas in both left and right colons and with different levels of experience. The present trial also did not show any overall survival benefit of short-course neoadjuvant FOLFIRINOX compared with upfront surgery in patients with resectable pancreatic head adenocarcinoma. Our next journal club is the first Wednesday in April, April 3rd, 2024. Please have a wonderful day, week, month, and we will see you in April. 2024 is moving along fast. Okay. Thank you, everyone. Please take care. Bye.